Thank you so much. Welcome everyone to our July Alcohol and Drug Policy Commission meeting. I really appreciate this intro kind of slide reminding us of our mission, opening doors, achieving access, belonging, and connection across Oregon. So I think let's go ahead and start with roll call, Ashley, if we could. And maybe we'll get a couple more people as we're doing that.
Great. I will start running roll call. Is Caprice Massey here today? Okay. Caroline Cruz.
Here.
Thank you. Debbie Jones, you're here. Eric Davis. Okay, Erica Fuller.
Here.
Thank you. Fernando Pena.
I'm here.
Awesome. Stephanie Damon Moore.
Here.
Great, thank you. Jennifer Kearley.
Here.
Julia Mines.
I'm here.
Great, thank you. Katie Jokinen. Okay, Kelly Minty. Maris Alden, are you here today?
Maris is out, I think, for 1 more month.
Oh, that's right. Okay, great. Monta Knutson. Okay, Moxie Loeffler. Okay, Mike Obiero. Okay, Sharon Dursey Martin. Shira Morella Simmons.
Shira's out on leave now.
Okay, great. Stacy Ondanitis. Okay, Tim Lynch. I think you're here today.
Yep. Thank
Great,
you.
thank you. Tony Vesna, I believe, is out, and Vanessa Nordyke.
I'm here.
Thank you. Nice to see you. Is Clara Rigmaiden in today?
I'm here.
Awesome. Hello. And is a representative for Senator Lisa Reynolds here?
Good afternoon. Hi, Kelsey McCauley here on behalf of Senator Reynolds.
Great, thank you. And is Rep. Tana Sanchez or a representative for Tana Sanchez here today?
I think he is just coming into the room.
Great. And then Ebony Clark, who I thought I saw come in.
Yes, I'm here.
Hello. Okay. Did I miss anybody?
It looks like Eric came in.
I'm here.
Awesome.
And did we get our new member, Stephanie?
Yes.
Okay, and
And I think-
Sharon is
Uh-huh.
coming in.
And I think I got everybody's name. So love that. Back to you, Debbie.
Well done, Ashley.
I'll let you know
Great.
about form. I need to look at the roster. now.
While you're doing that, just a reminder, members of the public, we're grateful that you're here. We do ask that you keep your camera off during the majority of the meeting, but we will have public comment at the end, and you can let Ashley know if that is something that you'd like to participate in just by sharing that in the chat. And how are we looking at quorum? Okay, I got it. Thumbs up. Great.
Yeah. we need
Okay.
form.
We'll turn just a quick regarding the agenda today. It's going to be kind of a nice one. I kind of call it like getting the family back together. Director Dolph will give us some updates, but the bulk of the meeting will be our opportunity to see where we are kind of as we've been working on our individual committee plans, and we'll be able to hear from everybody. And I really appreciate our ADPC staff for giving us this opportunity, because it is important that we have that continuum and see how we all fit in together in this important work. So, and there is this rumor I hear that we might get done early, but we'll see how we go. I don't want to break any promises my first time chairing the meeting. So with that, I'll turn some time over to Annalise, our director, for director updates, please.
Thank you, Debbie. And I will start off with the announcement that folks will remember at last month that we put forward Debbie as a recommendation to the governor to serve as chair, and we did get the official appointment from the governor. So Debbie is 100% here in her official chair capacity, and Sharon Dorsey Martin did join the meeting. So we are complete with our leadership. So from that, I'll run into commissioner and staff updates. At the end, I'm going to give Stephanie DeMond Moore time to introduce herself. Stephanie is stepping into Frankie's position as the attorney representative on the commission. So we're very excited to have her. Thank you so much, Stephanie. Did also want to announce, some folks know, I think, that Stacy Andoniadis stepped down from Care Oregon and is now the chief of staff at the Oregon Primary Care Association, which made her ineligible for the CCO slot. However, because Katie Jokinen is the SUD manager for Gobi, Katie has not been acting with her CCO hat on, although her knowledge in that realm has been very useful to us in order to keep Stacy on the commission, particularly since she serves a leadership position on health and safety interventions. We are switching Katie and Stacy. So Katie is taking on the CCO representative hat, and Stacy is taking on one of the provider hats. So just so folks know that their terms will not change, but it shifts that, which is a good time for me to remind folks that everyone who sits on the commission is in a statutorily defined position. I've had some kind of confusing questions lately about making recommendations for, say, our upcoming vacancy for the county commissioner. When Kelly Minty steps down, we have to replace Kelly with another county commissioner. And that will happen at the end of the year. Kelly's serving out the remainder of her time. As Caroline mentioned last time, she will be ending her term in September. And so a new tribal representative is in process. So those are commissioner updates. As kind of rolled out in roll call, we should be getting Maris back. I think it's next month. We did welcome this month, Shira welcome new baby Azalea. Beautiful name. And Tony, welcome new baby Amelia. So we have a little A trend happening here. And so they will both be out on leave for a few months. So lots of rolling absences here. Other updates, I mentioned this in my email to you all a few weeks ago. We did get our biannual legislative report submitted on July 1. Which was basically our executive summary of the comprehensive plan that hadn't been submitted to the legislature previously, with our first 6-month update. So that went into the legislature. The financial assessment draft, I'll be talking about that with the implementation update. I expect to get that to the governor's office this week. So that's really exciting. That was a heavy lift for us. Opioid settlement board announcements. I'm actually going to talk a little bit about that in infrastructure as well. But just know that the settlement board is continuing to develop with OHA their request for grant proposals that will be issued this fall. That will be one-time funding for 2027 to 2029. And we've been working with them on that. I think that's actually all my announcements today, because most of it will be in the presentations later. So I just want to turn it over to Stephanie DeMond Moore. We have a lot of Stephanies as we prepped her for to introduce herself before we get started today.
Thanks, Annalise and Debbie. My name is Stephanie Damon Moore. I am a public defender in Portland, and I've been doing that for about 7 years. And I also now supervise people in my office, including some of our case managers who connect clients with treatment. I'm really excited to be part of this group. I have been able to shepherd a lot of my clients into recovery services and treatment services, and have seen the highs and lows of that world and process. And so I'm really excited to bring some of my experience to this group and learn from all of you. And I am just here to start sponging things up and happy that this is a sort of review week so that I can do that. And really looking forward to working with everybody.
Thanks, Stephanie. And I can take any questions. I didn't have very many substantive updates, but if anybody has any questions before we launch into our big update. Awesome. All right, Debbie, do you have anything else before we get started?
No, just want to echo Annalise and I had the chance to touch base with Stephanie last week, and comes with great credentials, and we are really looking forward to the perspective that she will bring, and appreciate her saying yes. And the competition to find out which committee she wants to join is off and running. And so give your best pitch when you do your committee updates, and we'll find out where it fits. So I think with that, we all received the slides, but let's go ahead and move forward with that.
Thanks, Debbie. So before we get into which committee is the best or most productive, I'm going to kick us off with infrastructure, the overarching strategies. We're going to do each section, the committee staff and committee chairs, or in the case of recovery, our committee co-chair, Stephanie, is here to present with me for recovery because both Will and Tony are out. So we'll present the section and then we'll pause for questions at the end of each section. We're shooting for 10 to 12 minutes each. But as Debbie said, if we have a robust discussion, we have time for that. We've got a little extra time today. So next slide. So just as a reminder for infrastructure, I'm going to go through our priorities and the strategies in groups and give you an update. I would say this is probably the kind of biggest lift is leveraging, at least initially, leveraging our statutory authority to make data-informed fiscal policy recommendations for state agencies. So this really starts with the financial analysis that we've been working on. I have a tiny bit of preview on the next slide because it's not finalized. I don't want to say too much, but it's been here's what I'll say. It's been a really interesting exercise. High level, we're not going to be able to compare directly the 21-23 analysis to the 23-25. So I want to manage that expectation. We have a bigger number that we're working from this time that is in part from a small level relates to a little bit more money, but I don't want people to get too excited that there's been like huge investments and this is really documenting it. It's really more the bulk of funding in 21-23 and in 23-25 is Medicaid funding. That should surprise no one here. About 3/4 of the funding is for treatment in 23-25. And Mitch deserves all the credit on our team and a large team at OHA for really going in and taking a look at how they developed the financial assessment in 21-23 and ended up with a broader set of claims that we are going to include in this financial analysis. So the number is bigger, but it doesn't mean that there was more spending. It's that we're measuring more apples than we did last time. We also looked at peer services differently this time. So we tried the best that we could to categorize peer services across the continuum. So if it's peer services being in recovery support's great, but if it's really more in a clinical treatment milieu or harm reduction, for instance, we tried to categorize it. It didn't come out neatly. One other thing I will say, so a couple things we're still working on. One is we are trying to minimize, if not eliminate, all funding that's categorized as other. So folks might remember in 21-23, at the end of the day, there was a very small percentage of funding that was classified as other. We're really trying to eliminate that this time. So because we have that and the House Bill 3321 assessment happening, which is doing a deep dive into primary prevention, we do have a bucket right now in the draft that is other that we're hoping to have defined by September when we'll issue the final report. So those are a couple of provisions I want to put out there. We have a lot of lessons learned, I think, for how to approach this and how we'll approach it next time. I think we can start much earlier. We have a gigantic spreadsheets and have had many lessons learned from spreadsheet control and what agencies work well with a template and what agencies don't. So it's been really fun, much more to come on that. But that one pretty soon we're going to be able to check off and say we did that. And there's certain things that recommendations that we are putting forward to the governor that we continue to do analysis and dig deeper on some things over the next 2 years running up to the next financial analysis. So that's really the high level on that. We also have the 3321 analysis, of course, as one of the strategies. That is being led by the Prevention Committee and Third Horizon. So Wes can say more about that. That is on track for the legislative deadline of September. The one strategy in this area that we have not prioritized for these first 2 years is this piece to really do a deeper dive on the mental health, alcoholism, and drug services account and how that funding gets allocated to the counties. And that is in large part, and that comes from, just as a reminder for folks, beer and wine revenue. And so that statute goes back, I think, like 35 years or something on how that's supposed to be allocated. We didn't prioritize that for a couple reasons. One, they just updated the CFAAs between OHA and the counties. So really seeing how that falls out. And also we wanted to have the baseline of the financial assessment before we go forward with that work. So more to come on that one. Next slide. So I will give you just this like draft. You'll notice there's no actual numbers attached to this. Just to give you a little flavor. It is looking, and this is not exactly surprising. So the percentage of other fund versus general fund looks a little different this time. I'll have some numbers to explain why. The kind of, spoiler alert is for general fund, because we have a bigger pool of Medicaid, that makes the federal fund bigger, of course, but that all has a general fund match. And most of the general fund in our system is the Medicaid match. So once we have the final, you'll see that. Other fund, though, it's interesting because the opioid settlement dollars are starting to come into play, and that sits in other, as does cannabis revenue. So just a slight little preview there. Not surprisingly, as I said, treatment is the majority of funding. Next category is recovery, and then it goes down to harm reduction and primary prevention. And I'm not even going to give the primary prevention percentage because, as I said, we're waiting for that kind of other to get sorted out with 3321. But as you can imagine, much less money is spent on primary prevention and harm reduction. Also, just there's some interesting things that folks will be able to see in looking at agency by agency. We have a much broader group of agencies this time than we had last time. So we have spending from, I'm trying to think what we didn't have last time, OLCC, Office of State Police. We did some work with Housing and Community Services. It's a little harder to tease out with them what exactly is substance use disorder. So we're going to have some information on that, but we're not counting their investments in the totals because those big capital housing investments are so big, it would probably skew things. So that is the big preview for the financial analysis. As I said, more to come next time we meet, because we take off August. In September, we're going to spend a lot of time doing a deep dive on this and 3321. Next slide. So somewhat related in the area of infrastructure is fostering future pathways to stable and sustainable funding for the entire continuum of care. So we started a project that, again, I think will be informed by the financial assessment, doing comprehensive mapping of OHA burn funding, Measure 91, CJC funding, and opioid settlement resources so that we can really start to see where these may overlap or not overlap. We have an open position. Some folks might remember we used to have another research analyst. That position has been vacant for a while. We're trying to get that through. That person will help with this and help with some of the work we're doing on dashboards. So it's a little bit of a pause for that. But also one of the things I'll just mention in this area is it's one of these things that's going to continue to be an issue for us in comparing things across agencies when grants for services and agencies and definitions of services and agencies are so different that we can't really compare them. And so that is one of the things I'll point out in this first area. The way CJC defines services and the way OHA defines services are very different. So there's some ongoing conversations there and some work related to the governor's latest executive order that hopefully might inform that going forward. And there's certainly pockets of success starting to happen there. And Mitch will talk later about maybe talking later about some of the data work that we're doing that hopefully will help, but that's something that's going to hold up some of that work. A couple of opportunities here, but some realities as well in terms of looking at this and starting to look at strategies across different funding streams. A couple of opportunities that we've had recently with the opioid settlement boards, RFGA process that they're doing right now. We mapped out the comprehensive plan to the allowable uses of funding under the opioid settlements to inform that RFGA process. So when you all put together the comprehensive plan, you said settlement funding should be prioritized for things Medicaid won't pay for. But we didn't say, if the opioid settlement board has $13 million in one-time funding, this is exactly how they should spend it. So instead, we're starting to create these processes so that we can create a way to really start to connect some of this funding back to the plan and across the whole continuum of care. So that's been a great opportunity. Staff are also exploring some different processes with federal block grant funding and AMPAC, which Debbie could probably speak to ensure that when they put together the plan for the block grant funding, that it really is mapping to the whole continuum of care and what we need across the continuum of care, and not just maybe what's right in front of us or the always going to treatment, but really looking across the continuum of care. So that's fantastic. A couple of just, risks that we need to think about here. One is marijuana revenue in general, and this will be highlighted in the financial assessment. We are really relying on cannabis revenue. It is a huge chunk of the non-federal funding that we as a state are allocating to substance use disorder, and that revenue just keeps going down. There is right now, medical marijuana is exempt from the tax. That is set to sunset at the end of 2027. It's entirely possible that the legislature will extend that sunset because they don't want to tax something someone is using as a medicine. If that's the case, then that gap between where we are now with cannabis revenue and where we're going is just going to get bigger. So that's something to think about. There's also just the restrictions on federal funding, the Dear Colleague letters that have come out related to overdose response and health and safety interventions. As federal funding kind of changes and things get narrower and narrower, that's something that we have to think about in terms of the sustainable continuum of care. And then, of course, the HR1 impacts and shrinking Medicaid as we go forward. So those are things that we just have to keep in mind. Fernando, if this has to be asked now, otherwise I've got 2 more slides real quick, and if you can hold your question to the end. Okay, I'm going to take that to mean you can hold it. Thank you. Okay, next slide, maintain staff commission to implement the plan. So this one is pretty straightforward. Our goal here was to really maintain a dedicated staff with expertise and the near-term goal, I think this is underneath this, plan execution reflects momentum and committee activity, state agency and local partner action as a result of ADPC staff engagement and assistance. I think you'll see today in the activities of staff as they go through the rest that they are becoming much more embedded across the agencies. We've increased our connections with local ADPCs. In the coming months, we'll be presenting on a survey I did of the LADPCs. We're getting some ideas on how we might support those committees across the state. And then just really continuing to maintain cross-agency strategies. We definitely have potential for growth on this one. I'll be honest about that. We're re-examining the quarterly state agency meeting we do. That is when we bring all the representatives of the state agencies together. The plan is really, I kind of in my notes here wrote just a piece of paper to many of our state agencies. It hasn't gelled to the point yet where our state agencies come together and say, here's what we need to do for the people that we serve. So potential for growth there. I would say we've had some success with being proactive, and that's something that we need to continue to lean into as a commission. Maybe writing more memos or letters or white papers as a commission in order to kind of put our position out there. We are certainly not considered the last word on substance use disorder policy, which I think is what some people really envision for the ADPC. We're definitely not there yet. I think our voice is growing, but we have room to grow. Eric, I've got one more slide. Is it possible? Okay, awesome. Okay, one more slide and then Fernando and Eric. Okay, so last slide is good news. But these both, I will just say, are things that are really beyond our control as the ADPC. So we really have to think about like what our levers are, which I think we have done in our activities here. So we recently executed the contract to do an annual all payer all claims analysis. So that will be presented later this year. That's very exciting. Folks who were there last month will remember, and it's also in the notes, we're forming this ad hoc substance use disorder data work group in conjunction with the settlement board and with OHA. Ebony has been a tremendous help on this, along with Medicaid. Emma, Ebony, and I are kind of serving as the executive support, and ADPC staff is going to staff this group so that we can move forward some internal data alignment work within OHA and make sure it has the backbone to move forward. So that's amazing. We also have under this one really focusing in on culturally specific responsiveness and financing, procurement, and service delivery, and aligning statutory definitions related to culturally responsive, culturally specific, and linguistically specific said services. And that needs more focus. There are some folks other places in state government who are really looking at procurement. So that is a much bigger thing, but something we can continue to think about how to leverage. and then thinking about how we start to align those statutory definitions as we go forward. But those haven't been prioritized in these first 6 months. So that's my update. Fernando and then Eric.
Yeah, thank you. And the question was around the marijuana tax revenue. I was wondering, do we have a sense of how the rescheduling of cannabis by the federal government might impact the tax revenue at all?
No, no, is the short answer. There is a cannabis groups meeting convened by Senator Przansky and Representative Nguyen, and I and OLCC and I think an OHA rep are part of those groups. We really haven't talked about revenue. There hasn't been a suggestion yet to kind of, in fact, I would just say the only hints I have heard are more about moving out either continuing the sunset or continuing the tax exemption of medical marijuana or removing it altogether. So I think for revenue purposes, there is still some energy about keeping that tax exempt. There are some ideas about looking at cannabis as one plant, but right now the rescheduling really doesn't do anything to help that because we still have intoxicating hemp that is regulated separately. So we are very far from that.
Well, thank you. Thank you for the clarification. Yeah.
Eric?
Thank you, Annalise. Thank you for sharing that information. It was very helpful to kind of see, some of the progress we've made, but also see potential avenues for what we could explore further. I think one of the things that stood out to me was the idea of this cross-agency collaboration and partnerships. As I think about the addiction field in general, I think one of the organizations that has tremendous influence on substance use disorder providers is OHA's Behavioral Health Licensing and Certification Department. I just want to throw out there the idea that if that's the organization and the policies that have a huge impact or significant impact on behavioral health providers, is there a pathway or an opportunity for the ADPC to partner with OHA and look at some of the policies that have impact that might have a negative impact on clients, a negative impact on providers, or the community at large, and find strategies where we can come together and address this so that we can continue to enhance the quality of care, but at the same time, reduce the administrative burden to providers?
That's a great question, Eric. And I think you'll hear, particularly when you hear Mitch's presentation from treatment, you'll hear where we've had some successes doing that, and maybe other places where things are falling a little bit behind. The licensing and certification division is in Ebony's division. And we do meet with staff from licensing and certification, and we have some things we brought to OHA around COA, for instance, to varying degrees of success. But I do think, Eric, I think that is an example of where we can lean in harder, and we're going to have to be really proactive and really specific in what our ask is and what the impact is and the timeline that we're asking OHA to act on. Ebony,
Thank you.
probably want to respond to that too.
Yeah, no, appreciate the question and, understand, kind of the intentionality and the goal around outcomes and impact around behind the question. So appreciate that. And I would just say that, our goal is to be in thought partnership. Our goal is to co-create as much as we can. I think that there's sometimes, there are different requirements, whether it's attached to CMS, specific to kind of federal policy and rule. There's things that we have to have if we want to continue to get funding. There's things that we have to also be able to demonstrate and assure in terms of thinking about quality services, safety, accountability. But in the end, it's about how do we have a adaptable, nimble, transformative system that first and foremost meets the needs of the individuals that utilize the system and are relying on the services. And we have to do that in partnership with our key partners. And so, we're going to continue to always be mindful and thoughtful around how do we continue to, leverage different tables, community engagement, our RAC process, but then also just individual conversations. And so the more that there's, kind of specific kind of questions, if there's like something that like you might be specifically thinking about, that's always helpful. So I guess that's my long-winded way of saying that, appreciate the question and we're always open to do better.
Thanks, Ebony. So I think we are ready to move on to prevention.
Yeah, hi everybody. West Rivers Senior Policy Analyst with the Alcohol and Drug Policy Commission. I'm here to talk about the progress of the Prevention Committee for the first 6 months of this year. If you go to the next slide. So I think we have been extremely focused on two major aspects of the strategies. And I think that's reflected in some of the work that we did last year of wanting to build an infrastructure for primary prevention in the state. We had to be extremely thoughtful in one, making sure that we are all, making sure that we are all on the same page with respect to how we define primary prevention and what is in and outside of that definition. And then how are we going to support people to meet that definition? So the work is off and running with respect to House Bill 3321. So our colleagues at Third Horizon did quite a bit of data collection, particularly in the month of June, both at a state agency level, but also at a organizational level and local community level, both through surveys and informational interviews and focus groups, really trying to get at how public finance for primary prevention operates throughout the state. What are some of the gaps? What are some of the things that are opportunities to expand how we define primary prevention as a primary prevention subcommittee? And that work is in the process of analysis. So we are borrowing what we have got from the larger financial assessment, the data collection that Third Horizon is doing, both at a state finance, but also at a programmatic grant level, and at a local finance level. Packaging that all together in an analysis that's happening right now as we speak. What we're hoping is that draft analysis can start to move out into the public sphere at the end of July and early August, with the final results being due to the legislature in September. They are working hand in hand with the Primary Prevention Committee, reporting back to the Primary Prevention Committee. Committees providing feedback, particularly around reach and making sure that we are hearing from everybody that we need to hear from. But the hope is that we have a really strong first go at understanding Oregon's primary prevention system in the fall. And that would also inform the second strategy around developing a center of excellence to support all of the workforces that are supporting primary prevention throughout the state. So I'm going to do a deep dive on that second bullet. The third thing I just wanted to say, and this is to Annalise's point earlier about staff being embedded in agencies. So we have really been working hand in hand with OHA and ODE on developing out ODE's mechanisms for getting community input with respect to their work with schools and school policy in particular around primary prevention and substance use prevention. And so that is borne out in them developing this community advisory group, which OHA and ADPC will help to staff. And so that's a big lift, and that's going to start up in the fall. namely starting to kind of look at the rules around primary prevention planning at a district level. Right now, we are right on time with primary prevention. Thank you, Debbie, for keeping the trains moving. And so we are about to move into a conversation around governance, but as a committee, with the hope of having a full scope of the Center of Excellence by the end of the year, the calendar year. And so I'll talk a little bit about that work really quick, and then I'll open it up for questions. Next slide. So the committee has taken the last couple of months, by couple, I mean several months, to really focus in on what do they mean by a center of excellence. What does that mean? What can we do to support people in doing the work in communities? So they have developed 6 pillars for support, and I'm gonna name these at a high level. We have dozens of pages of documentation for each of not each of these, but as a whole. So like if you have questions specific to any one of these pillars, please ask. I probably have more detail than you want. But I'm gonna start here. The first is a knowledge and resource infrastructure is to build a centralized clearinghouse for evidence-based and culturally informed practice, culturally and community informed practice. Right now, we do have clearinghouses at a national level that have varying degrees of functionality. Nothing that captures quite what is happening in Oregon and who is doing what with what resources. And so the thought would be is to centralize kind of database that's pulling from all of these existing resources and adding Oregon-specific lenses in there that is searchable and helpful for folks who are approaching an issue in their community and looking for resources and professionals to support them in doing that. Just gonna pull up my note really quick. I think really searching by evidence-based practice, community-defined practice, culturally specific practice, being able to search through that with specific tags for each of those things, how that's incorporated into school curriculum, if it's incorporated into school curriculum, if that aligns with the Oregon Health Education Standards, just a large inventory of pieces. Also, knowing the environment we face with respect to finances, a cost-benefit analysis of each of these approaches, and having information related to that is really important for communities to understand. The second pillar is foundational advance in leadership pathways for workforce development aligned with standardized statewide competencies and supportive state certification and national leadership accreditation pathways. I think we spent some time, particularly in the planning process, really identifying that there are a lack of certified prevention specialists in this state. Where this committee has evolved to is that there are multiple ways to achieve the workforce that we want to achieve outside of the certification of prevention specialists. Certification prevention specialists is great and it is a tool. But what that certification really says is I have a fundamental understanding of competencies around primary prevention. And that is what we want to spread to all levels of the workforce, from high school health education teachers to folks who have been doing certified prevention or had a certified prevention specialty for a long time. Making sure that those competencies are refreshed, understanding what is out there, and making sure that we have workforce plugins across the workforce and in different sectors of our workforce. So I'm going to move to the next one. Rapid response, strategic and agile response to emerging trends. So if folks have used, we borrowed heavily from OHA's Health Action Network, which is our Health Alert Network, which is a emergency preparedness listserv and notification system, which supports local public health entities as well as hospitals and other entities that are working in communities around emergencies. And knowing prevention, there is a lot that's coming up always around changes in drug use, changes in practice, changes in what is happening. We responsible for a social media feed right now around all sorts of addiction issues, and right now it's like social media. Like there are like various things that are coming out all the time around social media and approaches to social media. Similarly, what does Oregon need? Something that is rapid and can be supportive of community in the moment, and then directing them to resources to respond to it. So taking that approach and making sure that the center can address information as is becoming available quickly is really important for the committee. Number 4 is the translation function. So this is really thinking about what we have in academia, and where these clearinghouses sometimes stop short is they give you a whole lot of academic literature around a particular intervention without a lot of technical assistance on how do I do this practically or in an environment that does not have much in terms of resources to implement. And so one of the key functions of the Center of Excellence would provide that translation function. How can you approach this in a school? How can you approach this in a community-based organization? What does this mean? Like the academics around this mean for you in your specific community with your specific population of students or young people or older adults or whoever you might be serving. Taking policy, academic, and practice and trying to translate them so that folks, anyone can use this site and be able to use it in a way that will be beneficial to their community. Community coordination and alignment, that's number 5. That is really uplifting our local champions and making sure that they feel supported. So that can look anywhere from school prevention specialists to folks working at local public health authorities to folks who are working in our criminal justice system, making sure that whoever is the champion in your community has what they need to organize and support robust implementation of evidence-based and culturally informed processes. That also looks like getting people together to sit in a room and talk. So the power of a conference is not lost on this committee, and having gathering places where people can learn from each other in the state of Oregon is really important. So that's a key aspect of that. And then 6 is around risk and protective factor integration. So knowing that this center is a center of primary prevention excellence, really trying to understand where is the scoping line of that. And so bringing in risk and protective factors shows that we are looking at a broader set of interventions that and learnings and supports that might be beneficial for other domains such as suicide prevention or gambling prevention, but looking at these common core protective factors through the lens of substance use. But that's where we're going to start because we need to scope this out. But providing the evidence nonetheless of the other contributing factors of these policies and practices. So really thinking about it in that range, but also everything else and that is within our primary prevention definition, selective, indicative, and universal, thinking about how we can package that all together and making sure that people understand that it fits within their role and that they can see themselves in the primary prevention of substance use. So that's where we're at. We are about to get into a conversation of governance and who will be responsible for making sure that we implement the vision of this. And like I said, I'm happy to provide more depth offline with some of the documentation that we have. And I'll stop there. If we can switch to the next slide for questions. And Debbie, you're here, so I feel bad taking all your thunder.
No, it's a lot. And I think that Wes has helped us go through a very thorough process. Definitely we're kind of plotting around for the dream and not getting ahead of, okay, how would it be funded? Who's going to run it? It's just like if we had the dream, and being slow and meticulous and make sure we're covering all those things, which I think Wes, you did an excellent job at. So, in providing to the group. So again, any questions?
I just have a
So,
comment.
Yes, Gary, please.
Thanks so much, Wes, for presentation. I'm glad you pointed out that this is not going to be limited to just substance abuse, because when I think about risk factors in prevention, I also think about, mental health symptoms such as depression that could lead to suicidal ideation and some of the other symptoms associated with behavioral health. So I think that I'm encouraged to hear that you guys are addressing other domains as well.
Yeah, and I think that is part of it when we're talking about, that opportunity to address universal prevention. They go hand in hand, and then they still with the selective and indicated, but being able to see that, and then eventually how we can be a really strong handoff to the work that the rest of the committees are doing, so that there are no wrong doors, and we're identifying and preventing at earlier stages wherever it's at.
Yeah, thank you so much, Debbie. I'd definitely be interested in meeting with you or Wes offline to share some of the ideas that we have in place right now in Salem in our partnership with the local school district to implement some of these things you guys are talking about today. So it'd be interesting to share what we have and to find out more about what you guys are offering to see how we can align those. So,
Yeah, that would be great. Wes will help us set that up. Thanks,
all right,
Eric.
thank you.
Okay, I think unless I don't see any other questions, we ready to move on to the next subcommittee? Thanks, Wes.
All right, next slide. I think I'm going back to back here. Okay. Next slide. Now I'll share what the youth and our adult members of the OYEA have been up to. First, we have up and running a school-based pilot for early intervention treatment and recovery. To Debbie's point, thinking about how we can work with the prevention committee to take those warm handoffs and start to think about how schools build comprehensive systems of support. It's really important to the young people on the committee. And so I am very pleased to say that with the help of ODE and OHA, we have 8 pilot sites. I'll talk a little bit more about what those sites are doing here in a second, but we have 8 school districts and education service districts kind of combined through multiple funding mechanisms are implementing early intervention systems and really focusing on the SBIRT model of screening, brief intervention, and referral to treatment, but have also incorporated actual treatment services and recovery services, in some of their work planning. So we're really excited. I'll talk a little bit more about that as I do my deep dive, but that has been a big piece of emphasis that the young people have been really excited about is around schools. Home, we are working with OHA to pilot the inclusion of substance use disorder services into intensive in-home behavioral health treatment. There was a round of budget cuts, so it went from about a $7 million program to a $700,000 program. And we're going to have to go much smaller scale. So right now, we're really going to focus on the IBHT providers who currently have a COA for sub treatment. It's about half of them, is my understanding, or maybe 2/3 of them. And so what we're really going to do is work on them about how do you start to connect the services that you are already billing Medicaid for with this IABHT team. So that's in process. That RFI is going to go out any day now to the existing providers to tell them how they would use the funds, and we'll do a little bit of a pilot. Second piece, I will talk more about now, but I am very excited about our work with OHSU, the Oregon Department of Human Services, Child Welfare, and OHA to start to build rapid assessment and referral systems for youth and child welfare who are at risk for overdose. And so that work is well off the ground. I will talk a little bit more about what that means here in a second, but I just wanted to name that. Um, Stephanie's going to talk about this in a few minutes, but OYA drafted recommendations to support the Youth Recovery Community Centers work that's underneath the larger Recovery Community Centers effort of the Recovery Committee. So she'll point to those here in a few minutes. But it has been a really true partnership between the Recovery Committee and our OYA to figure out how do we take the great work that the Recovery Committee has done and figure out how does that apply to young people. And so the young people were able to develop some standards of what they thought is youth facing. Stephanie will go over a couple of those later. If you need my help, Stephanie, I'm happy to do that. But also thinking about how that could support a statutory definition in the future. So Will and I are working together on that to realize that. Carceral, we have a POP to sustain the CADC positions, a policy option package. So budget ask for sustaining positions at OYA that are supporting Eastern Oregon and the girls facility down in Albany. We are working on culturally specific curriculum for OYA right now. They are already rolling out some gender affirming treatment curriculum. And then finally, working on the implementation of the new ASAM for guidance specific to adolescent care. So those are some of the pieces that we are moving along with OYA. Current risks, a lot of this is new, right? So as you saw with the IBHT, a budget cut can really significantly change the direction of a strategy. So we're kind of on edge with respect to additional positions and things like that. But yeah, I'll move into the specifics very quickly. I just want to give you a map, next slide, a map of where our school-based pilots are. So right now we are currently at Multnomah ESD is implementing a CAC school role in some of their alternative schools. One thing that you should note is that these are all alternative or rural schools or a mixture of the two. That will change over the course of the pilot, but right now that is where we're concentrating our efforts based on the feedback of the Oregon Youth Addiction Alliance. The second is in Colton. It's a small school district in eastern Clackamas County. They are working at much earlier ages at elementary and middle school, really thinking about psychosocial education interventions. And so they are looking at that. Marion County, we are in Jervis School District, really looking at alternatives to suspension. We are in Jefferson County and Madras at Bridges Alternative School, Bridges Academy. It's an alternative school, and they are working on both SBIRT program and then recovery programs for the youth that go to their school. Finally, then the first group. We're down in Southern Oregon ESD is implementing a treatment in school program. So they are in one school doing universal screening, and in another they're doing indicated screenings, and then supporting with actual treatment providers on campus, outpatient treatment providers on campus. Brand new to our group are Sisters School District through a program that's run out of Deschutes County called Upshift. It is a SBIRT program, an alternative to suspension program, so adding a recovery element to that school. We are in Grant ESD, which is working on some teen intervene program, as well as an enterprise school district who is working on a teen intervene program. And all three of those are added with the rural health transformation dollars. And so we're really excited to get these up and running. We are also supporting ODE to apply for some of the federal grants that were available to expand this program even further. And so it really is a braided funding program in which all of the agencies are putting some financing towards building out these supports and staff time in particular. Next slide. Quickly, I just want to go through how these home initiatives work with respect to child welfare rapid response. A lot of you know this. I just want to make sure that for folks who are kind of new to how substance use intervention works at ODHS, or how we wish it would work and how it works in reality, are two different things. So this is kind of how it's set up, or how it kind of appears on paper. Is caseworkers work with young people and families with substance use issues. Substance use is a large driver of child welfare interaction in our state. ODHS and child welfare have what we call recovery support teams in each county. Those folks make referrals to local treatment providers, and then those local treatment providers connect with the families and the caseworkers to work through getting access to treatment. Next slide. How it often works in many places across the state. Caseworkers work with families. You see, I faded out the youth. They do not have the skills or the competencies necessarily to work with young people with substance use disorder. They can work with the families to a degree, but they don't feel as comfortable with the young people in their care. What ends up happening is the local providers are also not set up to work with young people, so we miss out on that treatment access loop. And what ends up happening is we get supports for the adults, but not necessarily for the young people. And then so it is kind of a constant shift in support inside of a family, and that young people often get left behind in that support. Next slide. What we're proposing and what we have in front of Department of Justice is a memorandum of understanding between OHSU's new specialty clinic for co-occurring disorders to support ODHS with rapid access for young people in their care. That would not only be around some telesupport with treatment engagement and assessment, but also true supports and case consultation for caseworkers. So really going hand in hand with caseworkers to support these young people in engagement. OHA and OHSU combined with SOCAC would be responsible for maintaining a network of local youth providers, or providers who have supported young people in the past. And then you really start to create a care team for young people, and try to avoid what we've seen so many times in the past of young people slipping through the cracks, and potentially overdosing. And so what we're really excited about this is the access to engagement. We're going to really lean in on supporting OHSU's linkages with peer providers, but also their expertise and their ability to prescribe and to engage young people with medications. So this is what we're aiming for in this early pilot. And yeah, I think happy to take any questions. I know I'm running short on time. Yeah, Mike.
Hey, Wes. Thank you so much. It's amazing work. Seeing all those OIAs all across the state, I think is super encouraging. So well done to the whole team. My question is with regards to the school, like Multnomah ESD, I know that runs the Donald Lee Long detention education program. Was there a connection with them, or is that something that you will all look into after the pilots are done? Because that's a huge component within kind of a really big area in a situation that I've worked with at Multnomah ESD before, and they're really hungry for a lot of support around substance use and behavioral health. So I'm just curious what, if any, discussions happened with them, and or if they in the future plans for the expansion of the pilot program.
That's a great question. I think we're tackling that in two ways. First, the CADCs that are employed by MESD support both Donald E. Long and so their programs within Donald E. Long and then broader. So they're really looking at this as kind of a team approach, and we're also building in some systems or they're using the financing to build in some systems that no matter where you approach one of their CADCs, your access to kind of some case management services is it's pretty cool, though, what they're building with respect to tech. The second thing is separate from the school pilot, we really want to think about our support for juvenile departments just in general. And one of those things is this work with with the ESDs in particular, because they have such a great relationship regionally, both with the schools and with some of the government entities that are interacting with youth outside of school. So juvenile departments being one of them. Secondly, like how do we start to build in this type of support that we're building for ODHS? Why don't we have something like that for folks who are serving the juvenile departments? And so that's another thing that we're looking at that's kind of separate from the schools pilot work, but I think interactive, because we're talking about the same set of kids. To your point, is like if you're in an alternative school setting and you're being seen by a CADC, how's that care following you? Should you wind up being in the custody of Donald Lee Long or something like that. So that's something that we're really thinking about, Mike. Vanessa.
Thank you, Wes. Great presentation. As many of you know, I run CASA of Marion County, so we work with children in foster care exclusively. And my question has to do with the mobility of these youth. I'm so pleased to see more resources and clinic opportunities becoming available. One thing I can tell you from the reality of the system is that these kiddos tend to be very mobile. They may be removed from a household in Marion County and placed in Coos County. They may be there for a time, and if that resource placement doesn't work out, then they may move again. So this is a very mobile group. And obviously, when we're talking about treatment, having consistency, having familiarity is really important. So I'm wondering, how are we going to serve kids that have housing insecurity who are moving around the state quite a bit for a variety of reasons, not just foster youth, but other vulnerable youth populations?
Yeah, I appreciate that question, because I think the heart of this pilot was that young people move around a lot. And so we need a resource that's available to follow them. And so one of the issues that we were coming up with is like, actually, some of the child welfare offices, the local offices, are very good at supporting young people with substance use disorder needs and navigating that system. It's when a young person moves to a different jurisdiction, or they are placed in a placement that doesn't necessarily have the same connection, and caseloads are so high, all the things. And so having a centralized resource for us was really important, kind of standardizing that process by which child welfare workers and resource families and others are approaching the system. There's this unified resource that goes across all the state. The second is there's a second and a third thing. A second thing is what we were hoping is with tele supports that in some cases we can meet the young people where they're at. So if you have a caseworker who is seeing a young person, if maybe they're in a temporary lodging situation, how do we support that young person where they are before in that exact moment when they have a willingness to change or want to seek help? How do we be there with them in that moment? And the third thing that I think is really important that we're hoping to get out of this is to really build out one of the things that I think child welfare has really asked our help with is building a bridge to youth peer recovery supports and in general engagement. I think our young people would say this, it hits different when it's coming from a peer and a young person, engaging that young person in the place they're at, because they're often so mobile. So I think those are kind of some of the engagement realities that we're thinking about. Those are not perfect answers, but that's something that we're hoping to draw out, is like, how do we support these very mobile young people with this pilot?
Thank you, Wes. And I just point out in the chat, I'd be more than happy to connect you with the Oregon CASA Network. We are the network of all of the court-appointed special advocates who work with children in foster care around the state. We see so much substance abuse and substance use disorders in our line of work, more often than not. So I think we would all be very interested in learning more about these pilot projects when you're ready. as they roll out perhaps. But let me know. We care so deeply about our kiddos, and they will want to know what resources are out there, especially emerging resources. So we can chat offline. Thank you so much.
Any other questions? Okay, great. Thanks so much, Wes. Let's continue to move on.
So Stephanie Cameron is here to kick us off on recovery. Stephanie, do you want to kick us off, maybe introducing folks who haven't met you before?
Yes, thank you so much, Annalise. My name is Stephanie Cameron. I'm the founder and executive director of Restored Connections Peer Center. Restored Connections is Lee County's only recovery community center. And so it's been a great honor to work on this project. Also, thank you so much for allowing me the opportunity to share the work that we've done while some of our fearless leaders are out on some much needed vacation. Yeah, thank you so much. So one of the things that we've completed at this point in time in the recovery committee is really solidifying the definition of what a recovery community center is. I know that last month I sat in on the full commission and everybody was updated about the leadership summit where we really came together in person. Thank you to the Peer Company for giving us space during Peer Apocalypse to just really start looking at the components necessary for a recovery community center, and then also providing us an opportunity to just gather as leaders of existing community centers, recovery community centers. So this is a very large kind of body of text, and I was debating whether I was going to read it, give some space to let everybody else read it. And I think one of the things that I'm going to do here is allow everybody to read at their own pace and then really start to talk about the areas that are in bold. So I'll start talking now. Hopefully everybody had an opportunity to read. If you're anything like me, you can't read and listen to somebody talk at the same time. And so some of the pieces that are highlighted are really some of the core components to what a recovery community center offers to the community in which it's embedded in. And the pieces that must be, us as a group, we decided they really must be there in order to assess whether the organization is a recovery community center or not. The other thing, and Will's not here right now to talk about this piece, but he was able to identify that each one of these bolded portions of the definition can actually be a data matrix. And I hope I used the right word. I'm not a data person, but they are components of the definition that we can quantify, we can report on, we can gather statistics and really start to represent data. And as Annalise had talked about earlier, like we need data-driven outcomes and we need to be able to talk about the work that we're doing in terms of data. Next slide. And here they are again. So Will created this really great slide where we can talk about a recovery community center as identified in the previous slide. It's non-residential, it's peer operated, has a paid director usually and recovery staff. It has drop-in hours, peer support. Typically it's free. It helps individuals build recovery capital. And that's going to be really important, especially in the next portion of this update. Other things that we offer, recovery community centers, our social activities. We help foster relationships, navigate communities and social services. We host or open our doors to mutual support meetings. We have connections with employers, education. We help with advocacy, both self-advocacy and system advocacy. And then there's typically volunteer opportunities. I do want to say something right here. We took a lot of care when thinking about rural communities and resources available to any particular recovery community center. And so one of the important pieces, it's not a must that all of these are components within a recovery community center, because we know, especially with new centers, they might not have a paid director yet, or maybe they don't have opportunities for a robust volunteer. But there's a mixture of these associated, with the number one being non-residential. Participants at a recovery community center are youth and adults. And thank you, Wes, for giving me that little plug. We will be talking about the work that OYA came and shared with us, because on top of this definition, there is going to be a subcategory or an appendix, an addition specific to youth, because it's its own population, and there's a lot of other care and considerations that need to be taken in to account when we're providing a recovery community center for youth. And so they showed, not just at the summit, but they also came to our committee and shared with us their views and the directions that we need to take, or we should take into consideration when we're providing services specifically to our youth community members. One thing that also came up that I thought was really, really important is the piece where we're talking about experiencing challenges or obstacles consistent with recovery from substance use, or those who are in remission, right? Or those who are actively working some sort of self-identified recovery program, and maybe substance use isn't a component of their current journey. One of the reasons that's so important is because there's a lot of other drop-in centers or day centers that don't really focus specifically on substance use or recovery from, or the process of recovery from substance use disorder. And so really making sure that that was in the definition to kind of help guide. Are we looking at a recovery community center? Are we looking at a day center? Are we looking at a crisis intervention or a crisis drop-in center? Because they're very different. And another piece that is extremely important is that if a recovery community center cannot offer culturally specific services, we need to have a network of services that we can refer to. And I think the thing that has been really helpful as a leader in a recovery community center is, with the recovery committee, we get to learn so much about other programs and other services similar but different to ours. So those referral pathways become easier. I mean, we know where we can lean in times of making sure that somebody's needs are being met appropriately. Next slide. And so these are some of the recommendations that came from OYA, and it was so amazing not just to hear a member of OYA speak at the leadership, but really just being introduced to the committee members and their perception and own personal experience with recovery services specific to youth. And the vulnerability and courage it took for some of them to share what they've experienced does not go unnoticed by myself and by the rest of the committee. Next slide. Yeah, so some things so very important: ensure that structure, safety, and boundaries. Make sure that all staff working in a youth recovery community center are trained to work with youth. Also, and I thought this one was really amazing and so kind of informative, is make sure that the youth are also trained on the appropriate relationships with those staff. There was something shared just about uncertainty on what the roles are, where the boundaries lie from the youth perspective. And that was, when it was being shared, once it's said out loud, it seems like, well, of course, but until it's voiced, I can understand how it could be such a dangerous blind spot to providers. And it's been a blind spot that's been there for decades. Making sure that trauma-informed protocols and reporting ethical behaviors all must be informed of process. So a part of the onboarding that they were talking about is how do they file a grievance? Where do they file the grievance? How do they report, unethical behavior? And what is that unethical behavior or those boundaries? Another one is eligibility of access for certain age cohorts. So we have, the age difference between 14 and 19 is very huge. And so making sure that access for certain age cohorts are really defined. So 14 to 18 and then 18 and up. Make sure that there's a community integration component. Also for youth, transportation, huge. Many of our youth don't have access to reliable, safe rides. And so they wanted to make sure that all youth services must have a transportation component. And then also very much like it was outlined in the original definition, there needs to be access to resource navigation, youth support trainings, cultural sports, language, and transition planning. So when somebody has reached 18 and it is time for them to move on to what would be considered adult services, is there a really strong transition plan, warm handover? Does the youth understand where they can continue their services and how to access those services? Next slide. Governance. So youth-oriented OCC shall have youth leadership opportunities. So once again, when we're looking at Recovery Community Center, a peer-led Recovery Community Center, that would indicate that embedded in the leadership of that Recovery Community Center would be youth voice. So that includes youth participation, peers in the organizational decision-making, youth-led peer programs, youth-informed choices for programming, and help with youth in community leadership. So once again, when we're talking about that self-advocacy and system advocacy, really making sure that a youth-focused Recovery Community Center is helping youth with that same development of advocacy skills and participation. Next slide. Oh, well, that went a lot faster than I had anticipated.
And
I love that.
That's great. I will be quick on the Recovery Capital because we actually spent part of the meeting last month talking about this example of applying Recovery Capital framework to recovery community centers. But this is really the part 2, and Will really wanted you all to have the slides along with the definition of the Recovery Community Center because we're really thinking of this as a whole package, right? These centers are developing across the state, but they're not defined anywhere. So let's all agree to a definition that is minimum standards, and also with it, what are some of those measures that we can start to gather across those centers to show progress in Recovery Capital, to show the places of recovery centers in the continuum of care. So it's kind of a fun little experiment almost for the ADPC to be in kind of on the early end of the development of a service, and that we can kind of set the metrics in place and start to measure it over time from the very beginning. Next slide. So just a reminder how Recovery Capital really fits in with a recovery-oriented system of care, which is the framework of our whole plan. If we increase Recovery Capital, and this doesn't just apply to recovery community centers, but that is the framework we're using here, then that is going to be one of those markers that rolls up to our big 3 that we will start to see some progress. I think, let's see, next slide. So next slide is just a reminder for folks on the 4 domains of Recovery Capital. And then if we could go down to the next. Yeah, so this is really spelling out, as I was saying, why the committee really wants to explore recovery capital measurement in this context. It will allow for standard measurements of individual growth. And it's something that is an existing survey that this could help us over time. It would help us in reporting to the definition to really show the services of the RCC and a way to measure it, in reporting to community. And then the committee very practically wants to think about not just how, we report these things out to the ADPC or to the state to show, but because this is something that's not sustainably funded, it is a reality of how they exist, that they also need to be reporting for foundation grants and for other things. And so how can we bring those things together in a way that really aligns with the definition? The next slide is an example showing the 10 questions that are part of the BARC 10. So again, this is just an example for everyone. And the example here is that New Hampshire kind of had a similar approach, although I think they had their definition before they even started funding recovery centers. And they adopted recovery capital, but that gave them the opportunity to show that in just a 1-year period, just looking at the center model, not all the other supports in the community, that they were able to increase recovery capital by 5%, which may not seem like a ton, but that is very significant that they were able to do that in just 1 year. So that is your reminder of recovery capital. And Will is happy to talk about that anytime. Next slide, this is the last piece, just kind of tying this up. So as Stephanie reported, the committee has been really focused on this recovery community center definition and really establishing it in a community from the ground up. And so that's taken a lot of work. That is not the only thing that Will has been working on. In addition to kind of thinking about recovery capital and measuring individual progress over time, the committee and Will are thinking about putting together a point in time survey for recovery community centers in order to measure kind of like an overall sentiment year over year. Recovery housing, this is one that because it is something that the system does need more funding for, that we didn't prioritize immediately. That doesn't mean it has completely fallen off. Will has been doing some behind the scenes work to look at the existing recovery houses in Oregon and the level of care that they are providing, or that they say that they are putting out there that they are providing, and kind of really looking at how that is starting to work with the funding. And then in peer services in general, there have been a lot of conversations, in particular with OHA Behavioral Health Division and the Office of Recovery and Resilience, and working across other state agencies, starting to really look at peer services and looking at those best practices in different settings. So that was my very, very quick wrap up there on recovery. Do folks have questions on the recovery work? Well, I really want to thank Stephanie for being here. We appreciate you so much. And for the committee chairs that do have co-chairs, I know they are incredibly valuable, and we really appreciate it. And so glad that we could get you in front of the commission. Thank you. On to treatment. So obviously we're not going to wrap up by 2:30. So I will just give Mitch, because I know you have a lot. We probably want to make sure that you do wrap up within like 12 to 15. So we make sure that Mara has her time as well.
No problem. I'll be somewhat speedy. Consider a lot of these slides as reference for all of you, though. Ashley, go ahead and jump right in. So quick things right at the get-go, some successes in quarter 2. We established 2 work groups. For those of you that aren't as plugged into the treatment work, this is really to support both an ongoing work need that we have coming out of House Bill 4002, which directed us to do this report that you've heard about a few times, and help implement any of those strategies we identified that are possible, that we're able to do so. And there's some still work there. The committee also at when we finished those recommendations asked that we stop looking so narrowly at MOUD and tried to expand further to other substances where possible. And so really this gave us this opportunity to look at this work group as an opportunity to kind of be a policy think tank in some ways, to really kind of get ahead of some of these issues rather than think in a reactive sense. We can think proactively and say, once the following things occur, these things might be possible. And then also, that work group is done in collaboration with the Opioid Response Network, because our other long-term hope is that we'll have a toolkit for how to stand up similar work groups in the future so that we don't have to be the sole host and conveners, and we can have specialty topic groups that we have the ability to say, hey, we know this is important to you. Here's a way to get that started and be able to kind of do what we've been doing in the background. So more to come there. They're ramping up, and I believe the September work group meeting will be the first time the ORN really takes a facilitation role from that. The evidence-based practice work group, there's more material on this about it later, but really that goal is that we're making recommendations for technical assistance that support the comprehensive plan implementation itself. Throughout the roadshow, one of the things we heard that was very relevant to the treatment continuum was that oftentimes changes have happened to providers, not with providers. And so our hope is to bring providers, payers, and agency staff along as we start to make those changes. We're also working on the provider landscape assessment, which I'll talk to you a little bit more about in a little bit, but that's really fun. And then there's also an internal BHD SUD work group that we were able to found that actually speaks to something that Ebony had said earlier in the meeting today, which is that treatment has a lot of levers that we have to make sure are pulled in the right order in order to not break the law, is probably the best way to say that. And so that as we're starting to look through a lot of these policy changes, this group has really been instrumental in me figuring out, like, hey, if we move this rock, is this okay? And is that okay? And who could we talk to? So that's been really fun to just build that partnership across agency. At risk that you're probably not surprised with, we're just paying attention to the work exemption requirements. If I'm being honest, I'm a little optimistic, at least for SUD care in Oregon, that that's not super radical, but we are paying attention to it. And there's some other staffing challenges that have led to some delays in deliverables that I'll talk about. Next slide. Here's just a little timeline for your perusing of what we've been doing over the last 6 months. The big, or 7 months. The thing that I'll tell you that I've really been kind of saying is the theme of year 1 is us assessing and saying, okay, next year is what we're doing. And again, this is really to honor that feeling of changing or causing change to the system, not causing change with the system. So one of the things that we've been trying to do is collect information and invite people to come speak with us. So that's why you're seeing things like the health share, high utilizer data coming through to figure out like who are our most acute care members that we need to be thinking about. This is also building into us drafting this provider landscape assessment that I'll talk a little bit more about, and so on and so forth. The biggest thing that I'll highlight that I just still think is really novel, back in January was our first like really, really big early win, which is the treatment court system changed their screening process to more accurately figure out what MOUD needs existed and who was accessing those medications. And that was done in alignment with a rule change that we're hoping to see happen near the end of this year, which will also require individuals to do a self-attestation of what medications they were offered in treatment to shore up that that's being an accountability piece for the system. Next slide. Big thing, and I'm not gonna like read all these. This is for your knowledge. Part of that year 1 theme, treatment is kind of an established treatment system. And I think any of you that were around during the kind of early days of Measure 110 or Burn got to see what it was like as we started to try to build a system within a system. And I think people tended to try to default to what we already had. And so as we're starting to change things, this is just taking a level of change management skill that I know for some of us who are maybe a little bit more impatient or want to see things happen rapidly can be a little unexciting, but trust me, like this stuff is working. But there's kind of the big factors here. Next slide. One of the other things that we've done over this last 6 months was decided on how we would talk to each other. Treatment is a little bit odd because we have addiction medicine providers, we have peers, we have treatment providers, we have administrators, we have payers all represented at the table. And one of the hard parts is we're all speaking a different language, even though about the same thing. And so what we adopted was this thing called the EPIS framework, which really, the short version I'll tell you is it allows us to talk about like what are the things that will actually make the system things possible to implement and pretty much try to make these things also sustainable. Because one of the things that I think a phrase that all of you might have heard is that Oregon is the place where good pilots come to die. And this is really us trying to solve like not a pilot, let's make something that is like a project that is destined to succeed long term and has a reason that we're doing. So next slide. Okay, so the provider assessment. So in the treatment part of the comprehensive plan, there's a lot of things that we had a baseline that were basically like, it's not good, doesn't exist, or it's like, it just kind of is inconsistent. What we want to figure out is like a better measurement that not good doesn't exist, or it just depends on the person. So we're working to develop an assessment that will go out across the treatment continuum with a goal of administering this fall, a report this winter, and then re-administering in 2029. That hopefully will give us a lot of ideas about what are the factors that impact treatment access, whether it's in physical health, behavioral health, specific systems challenges, maybe, and to be able to figure out like what are some of those inconsistencies that aren't as easily seen in data, because we won't know that, for example, maybe a provider doesn't refer to a residential provider in this quarter of the state because they had a bad experience with a particular payer, or maybe they found out that there wasn't good infrastructure to send somebody for transport there. So we'll have to figure out those nuances as well. A lot more than that. What this has really started with was like, I think we're at like 85 questions that we're drilling down based on a priority framework. They're all open-ended. We're making them more manageable, and then there'll be some branching. We have Third Horizons helping us. We're in good hands. So just know you'll hear more about that over time too. Next slide. This is just some information about what those work groups do. Email me if you're interested. We can just go to the next slide. Cool. So in our first goal area, which is expand equitable access to treatment options, DCBS is working on implementing a new report that is the result of Senate Bill 822, which is requiring commercial payers to meet quantitative reporting requirements like time and distance and network adequacy, similar to CCOs. So that information, when that's done, will come in front of the committee, and hopefully we'll start doing some fun stuff there. Like I mentioned before, we had this MSUD work group. I'm in the process of getting badge permissions to be able to do more frequent and interactive work with the DOC. Right now, I have an ongoing meeting with a few folks within the Department of Corrections to really kind of be talking about different policy levers specific to medication. This is going to later go towards this goal we have of doing some education for AICs, security staff, administrative staff, clinical staff, so we can kind of shore up some stigma problems that were identified in our roadshows. Let me just kind of see here. ASAM 4 is currently in process. So one of the things that we did at the start of this year was I aligned our kind of timelines with a lot of what ASAM 4 implementation looks like. They're starting on the most intensive service models, so we're starting on the most intensive service models, and that way we can make recommendations with those changes as they are relevant to OHA. Next slide. I already mentioned that internal collaboration group. This is really helping, like I said, to think about those those requirements that we have for federal oversight or other things related to discharge and assessment. For those of you that aren't aware, we have a different waiver called the 1115 SUD waiver that does have some different expectations around what addictions treatment has to look like in addition to our wants and needs at home. So we just want to make sure those things are aligned. And we can go to the next slide. First thing that I'll say is we're trying to facilitate improved transitions from one provider type to the next. So that could be from outpatient to residential, it could be residential to outpatient, it could be your doctor to hire like a withdrawal management program, for example. One thing that did just finished was OHA convened a work group to identify recommendations regarding the COA in hospital settings. They have indicated that there is a goal implementation date of January 1st, 2027, which aligns with our plan as well, to change the requirements to allow peer providers to bill in hospitals to support this work. So we're hoping that that will be the game changer. The CCO ops team is still working on some reporting data. They were one of the ones that was delayed that I mentioned. OHA, we had a presentation at the start of this year in treatment committee, but they're in the process of implementing the reentry healthcare benefit. This is from the Federally Consolidated Care or Appropriations Act of 2023, I believe, is where this comes from. It is a mandatory benefit. But it unlocks care coordination for eligible individuals who are leaving carceral facilities and anybody who has aged out of the foster care system, and that is a self-attestation form. So if you say that that applies to you, that applies to you. They've made it very flexible for entry. Next slide. And the last thing that I'll say in here is that this is our goal area that we don't have as much to show for because we're waiting on systems. And so the roads implementation is supposed to be in fall of 2026. I've been in a lot of background conversations just trying to make sure that we are both in the room the day that that's available to us and can start kind of doing some other fun stuff with roads data. What I've been kind of playing with that team is MOTS data to just try to see what we can get out of that legacy system and it not be for naught. So more news there. I think that might be all my slides. Any questions? Thank you so much.
Awesome. I believe it is me next. So if you could go to the next slide, that would be great. Thank you, Ashley. And the next one. Beautiful. So in case someone doesn't know, Mara Sargent, I use she, her pronouns. I am senior policy analyst with the ADPC, and I staff our health and safety interventions committee, which does our harm reduction work. So here is the some of the successes that we've had in the first 2 quarters. So OLCC started a hemp registry, if you'll remember, for intoxicating hemp. And it was scheduled to start in January, but there was a pause put on it due to a couple of extenuating factors. And so after, I believe it was 5 months, they started the enforcement. So there is a website that you can see all of the intoxicating hemp products that have been registered with OLCC. And they started by hiring one enforcement agent, and they plan to do more as things as time goes on. But the program is fee funded, so they're waiting to see how when changes go into effect in the fall related to some of the federal legislation related to hemp and marijuana, that they imagine that some things will change. So more to come on that. As you will see, we have been doing a ton of work related to naloxone. So I will share some more about that and the clarifying expired naloxone rules. That is something I will chat about here in a moment. Save Lives Oregon did their yearly survey of their participants, and they put in some questions related to where folks are getting naloxone so that we can get within Save Lives Oregon and outside of Save Lives Oregon where their participants are acquiring naloxone, so that we can get a really good general understanding of like the landscape of naloxone in the state, so that we can move forward with understanding that. Our at risks, this is something that keeps coming up, and I'm sure this is something that we have talked about and will continue to talk about, is In July of last year, there was a Dear Colleague letter that was put out related to proper uses of funding under SAMHSA. And then in April of this year, there was a new one released that clarified some things. One of the major ones being it reversed course on the ability of federal funding to be used for fentanyl test strips and other safer use supplies. So there has been some confusion related to that, and we've worked with OHA and people individually to provide guidance on how to apply for federal funding or to change the way that the funding streams are braided or blended. So next slide. As I mentioned, for the first 6 months of this year, we have been all about naloxone. So I just wanted to share a reminder that this was our naloxone strategy that was put into the plan, basically developing and funding a statewide strategy for the purchase and distribution of naloxone, ensuring access in rural areas and education. And then there were 3 activities underneath this. And so I have classified our progress on this by activity. So if you could go to the next slide. So under promoting greater use of MCAP and Save Lives Oregon, I've had some conversations with ODHS and OLCC about naloxone policies. I believe ODHS has some interest in putting naloxone in their buildings, so that's a continuing conversation. I've chatted with Arnaud and the OLCC about their naloxone policy, and so there's ongoing work related to that. Our financial analysis, we have, as many others have mentioned, we took care to ask folks to put naloxone in its own category to see what spending was done in that biennium related to naloxone. We also got access to MCAP's, MCAP is the Minnesota Multi-State. Oh gosh, I'm going to forget what the rest of the acronym means, but it's basically the bulk purchasing agreement that we have with this organization that allows us to purchase naloxone and other medications at a low price. And MCAP allowed us to view their data of the funding that they have, or of the purchasing of naloxone in the state through agencies and other folks in Oregon. So that was really eye-opening, really awesome to see exactly how much money we're spending on naloxone. It gives us another piece of the puzzle related to the naloxone landscape in the state. As we said, connected directly with MCAP and reviewed their data. Some more ongoing conversations. The Rural Health Transformation Project has some naloxone work going on, and so that is another piece of the puzzle, including that will move us forward in being able to navigate this landscape. Next slide. It's in service of supporting increased distribution opportunities. As I mentioned, Save Lives Oregon put in some questions in their yearly survey for us, and so we're going to be hearing from Save Lives Oregon related to that. And then we are in process of developing a naloxone toolkit, which will have basically our idea is to have everything all in one place. We've done a lot of really great work understanding where people are getting naloxone. Should agencies or organizations like to create a naloxone policy, we're going to have some policies related to naloxone in there. We're going to have all sorts of things. I'm in progress of getting that skeleton together. So that is the progress on that. If you can go to the next slide. And then on our third strategy, or third activity in our strategy, naloxone strategy. So we would like to encourage more naloxone distribution in communities with low access. And one of the barriers that came up when we were having the discussion about, who gets naloxone where and how it gets distributed in the state, was that sometimes folks are sitting on expired naloxone, and this seemed to be a big barrier. We spent quite a bit of time talking specifically about expired naloxone. So we've done a little bit of work. I have some time to sit down with OSP, our partners at the Oregon State Police, to talk about a model policy for expired naloxone, what that looks like, who can be donated to, who can use it, who can't. And Mitch and I also have a conversation upcoming with the Board of Pharmacy to clarify some of the rules regarding who can and can't have expired naloxone. And we've also heard that there's some potential legislation related to the Good Samaritan law in the works about including expired naloxone. One more slide, if you would. So this is sort of what's coming next. What I have, in addition to what I've already just shared, OLCC has been updating their trainings related to like server trainings. And so that is something that we're going to be helping with whatever they need. Our next strategy that we're going to focus on is related to drug checking. So we're going to be doing a drug checking in Oregon landscape overview. So keep your eyes open for that. And then we've been doing in Naloxone land, which is where I've lived for the past 7 months. I have OHA and ODE are in process of updating and moving out some language and toolkits, et cetera, related to naloxone. And so we've been doing a lot of alignment there with all of the great folks at OHA and ODE. So I know that was just a whole lot in not a lot of time, but if anybody has any questions, comments, concerns, I would love to hear. Okay, and if something comes up, please feel free to call me, text me, email me. I'm happy to sit down with folks and go through this in a slower pace if necessary. So thanks, y'all.
Thank you, everyone. Do we have one more? Are we ready for?
We made it through just in time to have a few minutes of public comment. If we
Big heavy lift. I know it was kind of like drinking from a fire hydrant, but it gives us some insight onto all the great work that our committees are doing, and I'm sure we'll be able to start to narrow those down. But please take advantage of all of our presentations. Each one of the presenters said, hey, don't hesitate to check in with me. I think they like being able to share. So do we have actually any public comment?
I have not received any messages or written public comment. No.
Okay, we'll give that one moment. If you happen to be here, if you want to raise your hand, Ashley will be looking to see if we have everybody on one screen. Okay, and their staff is sharing their desire and willingness to meet. We really appreciate that.
I do not see any raised hands.
Okay. Again, this was a big heavy lift, but this is the work that's been happening in the last 6 months. And many of you have been a part of ADPC longer than I have, but I remember when I was involved with the state's Addiction Mental Health Planning Advisory Council, and we heard about this ADPC group, but this is kind of landmark efforts. So I really want to send appreciations to our ADPC staff that have been guiding us, as well as all of the committee members. We're just, I think, getting started on some pretty incredible work that Oregon can be proud of. So a reminder, we're taking August off. And we'll be back. Many of you will still, some of you will have your committee members. We're not letting Wes have any time off, so prevention will be meeting in August. And we'll be meeting in September with some additional information. And with that, I think we're going to close it out for the afternoon. Thank you so much, everyone.